have a question, finally. Thank you for the Professor Curigliano. I see you online. And last month we see in Beijing. Thank you for your give us many conditions. And I have the two questions. The first is about the capivasertib 291. You know that in these clinical trials, both the ITT population and those with alteration in the PAM-pathway activity, particularly in the patients with AKT mutation, is a benefit. In your clinical practice, if you consider to use these drugs for the patients without the PAM or AKT mutation or PI3K mutation, the different mutation is different. If you have the opportunity to consider the different patient subgroups based on the specific mutation.
There is a study on this. The investigators did a subgroup analysis, and the benefit is exactly the same. If you have an AKT mutation, a PTEN, or PI3 kinase, you have exactly the same median progression-free survival benefit. If you remember in the Capitello, as you said, the benefit of capivasertib is also in intent to treat population. Is exactly the same. But FDA, EMA, and I can imagine also the Chinese authority, decided to approve only for the mutant population. So any single mutation is predictive of benefit, but overall, the benefit is an intent to treat population.
Yes, thank you. You know that maybe in clinical practice, we encounter the patients with ESR1 mutation or the PI3K mutation, core mutation. If you consider to use based on the ESR mutations or third combination with mTOR inhibitors or other AKT inhibitors or PI3K inhibitors together.
Usually the selection is based on the tumor burden and the clinical history. So if I have a patient who received the first-line endocrine therapy for more than 2 years, and there is a slight progressive disease on the bone, even if there are the two mutations, I prefer to use elacestrant or imlunestrant. If there is a little bit more disease and the patient is symptomatic, I prefer to use alpelisib or capivasertib, or we have some clinical studies actually with an oral SERD plus PI3 kinase mutations. And usually, you know, when I have patients like this with the dual mutation, I try to enroll her in a clinical study using oral SERD plus next generation PI3 kinase mutation.
If you could consider the CDK4/6 inhibitors, the time, the duration, the pure CDK4/6 duration or more than 12 months or other condition?
Yes, for me, yes. If you have a longer exposure to CDK, I prefer to use the oral SERD, yes. Yeah. But as I said, also, if you have minimal tumor burden. So I bring to you the example of a patient who received more than 1 year and there is a slight progression on the bone. In that case, I use the oral SERD, even if you have also the PI3 kinase mutation.
Yeah, thank you. And the last of the question, you know that the different ADC can be used in our country. Many people said that ADC and the next ADC in your clinical practice, if you should to choose, for example, to HER2 ADC, another TRAP2 ADC in your clinic, or just the ADC after that, the chemotherapy and another ADC?
No, usually, of course, I do not sequence 2 ADC one after another one. As you said, I also prefer to give in between a chemotherapy. But if you have a clinical study with an ADC with a different target and a different payload, I can also sequence it. You have many studies in China, so I believe you can sequence using an experimental ADC, as I do in my clinical practice.